Hello, good day. My name is Melinda Frost, and I'm leading the risk communications response for COVID-19 from the World Health Organization. Thanks for joining today's webinar with the EPI-WIN, the WHO Information for Epidemics. Today we're going to talk about stigma. The title of the webinar is The Many Faces of Stigma During COVID-19. We decided to do this because there have been so many numerous questions and issues around stigma. And I think it's quite poignant because I think one of my very first memories about COVID-19, even before it was called COVID-19 back in January, was when I was linking out through a little WhatsApp chat with my colleagues in UNICEF and IFRC. And I think one of the very first things we decided to do together was to develop a guidance or some communications around stigma, knowing that it was going to be an issue when it came to this disease outbreak one way or another. Now, 9 months later, I think we're seeing how this is really played out, both in terms of stigma against the individuals that originally had it, stigma now against, sadly, healthcare workers, stigma against those who have had COVID-19. This is going to affect the way we do contact tracing. And next, it may really affect those who have recovered from COVID-19. So we're going to talk about all of those aspects today and really get to some practical measures on how we can address stigma in the work that you're doing in the field. The ultimate goal at the end of this webinar is that we'll be listening throughout the webinar to try to pick out some key activities, products, or other things that we could be doing to really help you in the field be able to address stigma in your response. At the end of the webinar, we hope to do a quick poll to find out what activities or products or other would most help you do your work. So please pay attention to that aspect throughout the webinar. So today's flow, we'll start off with my colleague, John Kinsman, who's an expert in social and behavioral change from the European CDC. Next, we'll move on to Beena Thomas, who's a social and behavioral scientist for the Indian Council of Medical Research. Following that, we're going to hear from Vivian Fluke, who's the regional coordinator for community engagement and accountability in the Asia Pacific region. Next, we're going to hear from Hyo-jung Kim, my colleague here at WHO, who works in Attacks on Healthcare Initiative. She's the focal point for Attacks on Healthcare Initiative. And then finally, and last but not least, we're going to hear some really some groundwork, some grassroots work that's being done in Japan from Ryo Morimitsu, who's the chief psychologist, at the Japanese Red Cross Suwa Hospital. So that's the order of business today. I hope that you can pay attention because we're going to be starting off with some polling questions just to get a sense of where you're at and what experiences you've had or faced with stigma throughout the COVID-19 response and maybe even earlier. So we'll start off with the first polling question. And so please select the most appropriate response for your work area. The question is, how serious of an issue is COVID-related stigma in your country? First, is it not is it not an issue at all? Second, is it not a very serious issue? Is it a moderately serious issue? Is it a serious issue or is it a very serious issue? Please go ahead and vote. That'll kind of give our presenters an idea of how the situation is where you're working. Okay, we'll give it another minute here. And I think all you need to do is just click on the right answer or the correct answer for you. Okay, we'll begin to close this polling in 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Okay, let's end the vote. Great. Okay, so it seems to be it's a moderately serious issue where you're working. Okay, and I think we have one more quick question before we get going with John's presentation. So we'll move on to the next polling question. Okay, great. And the next question is, are you aware of any systematic efforts in your country to address COVID-related stigma? Yes, no, or you don't know. Okay. And we'll close the polling. And 5, 4, 3, 2, 1. Okay, thanks. So it appears as though the majority of people are not aware of any systematic efforts in your country. And by country, I think we also mean response area, your purview, your job, and so on, to address stigma. Okay, great. That gives us a little bit of information so that we can move on with our presentations. Before we begin with John Kinsman, I'd like to just ask that if you have any questions, please put them in the Q&A function at the bottom, where what I believe would be the bottom of your screen. Okay, don't put them in the chat room because we're tracking the Q&A function. So if you have any questions for the presenters, please go ahead and put them in throughout their presentation. We'll be pulling them out and using those during the question and answer. We have somebody tracking that for us today. Okay, so without further ado, we're going to go ahead and hear from John Kinsman from the European CDC. John?
Hi, and thank you very much, Mindy. And it's a great pleasure to have the chance to, oh, are you still speaking, Mindy? No? Okay. Hi. Thanks very much. And no, I can still see Mindy's talking. Am I speaking over?
Yeah, John, we can hear you. Yeah.
Okay, all right.
Go ahead.
So thanks very much. I'm going to speak about some basic principles of stigma and related to COVID-19. So next slide, please. And I should say greetings from a cool and windy Stockholm. First of all, what is stigma? The word comes actually from ancient Greek times. And I think it's always good just to have a sort of sense of where these things come from. It refers to a mark or a puncture that was burned into the skin of criminals or slaves or traitors. And it was a very specific action that was done in order to signify disgrace or moral pollution. So a very strong mark and a very strong thing that was done to people. And this term has gone through the Latin, now into English and into many other languages, which essentially speaks of a social process that involves labeling people as different. And essentially what it really does is to say, we are on one side and those people who we're stigmatizing are the other. It's us and them. So we're really separating the world into two different types of people. Next slide, please. I want to introduce you to what I think is a very helpful concept here. It's the imagined epidemic, which is really what drives a lot of the responses to an epidemic, including social responses such as stigma. The imagined epidemic is really how an epidemic is perceived and understood by people. And we're talking about any sorts of people, whether these are people working in national ministries of health, people working shining shoes on the street, or selling vegetables, or whatever it may be. Everybody has in their head an imagined epidemic. And this is the product of many different sorts of things that have happened in your own life. Rumors you hear, stories you hear, memories of previous epidemics, for example, SARS or the West African Ebola outbreak and so on. Media is a very important contributor to what gives people an imagined epidemic. Politicians and what they say, these also have a very important component in terms of driving particular narratives. And also the trust or the lack of it that people may have in medical technologies and in the government. Next slide, please. Essentially what we're doing with an imagined epidemic, especially earlier on in the epidemic, is to try to understand what's going on here. What is this disease? Am I safe? Am I at risk? What about my family? How can I avoid this? And it's an incredibly important part of the process that shapes a social response to an epidemic. Next slide, please. And based on the imagined epidemic, collectively and individually, people will respond in different ways. You have prevention, treatment, and control, which is your classical sort of public health response. And that is also a social construction, and we mustn't forget that. You have people who work in a way that goes above and beyond what you would expect of them, people who are altruistic. This is also a characteristic that we often see in epidemics. You have people who avoid to the extent possible. They flee to the woods. You have people who fly far away to get from it. And then you have blaming, scapegoating, and stigma, which are sort of all wrapped up in one. Essentially, as I said earlier, this sort of creation of this us and them thinking. And this can have a very, very serious set of consequences. So you have the full range of social responses, and I don't want to say that everything is all about stigma, because all of the social responses are there all across the spectrum. Next slide, please. So what about within the case of COVID specifically? We have a completely new virus. We have a lot of things that we still, even now, don't know. A lot of very important unanswered questions regarding transmission and about the cure. So we're in a situation where people are wondering, they're worried, and into that hole, as it were, of vacuum knowledge, misinformation can spread. Misinformation being information that is either wrong because people don't know what else it is, or because it's deliberately planted as being wrong, which you could also describe as disinformation. And the fact that there are so many things we don't know about can lead people to be fearful. And of course, over the course of this year, we've learned an incredible amount. And I think as a new disease, there has never been so much effort to try and understand a new disease as there has with this one in such a short period of time. So it's actually amazing what we do know, but still there's a lot that we don't know. And as a result of this, there is fear. And this fear can lead to blame, stigmatization, creation of the other. And what this does within a society is to create a sort of undermining of social cohesion. And any inequalities that already exist there are exacerbates. And this actually can directly and indirectly lead to the spread of the virus further. I think it's also important to recognize that this happens differently in different social settings, in different cultures, and over time. Next slide, please. Here we can see how the changes in the targets of COVID stigma have changed over the course of the pandemic so far. And there's many other things you could say, but I just want to give a sort of schematic representation of this. Initially, back in February, March, or so on, we could say that globally, a lot of the people who were subject to stigma were people from Asia or people of Asian descent, as they were considered to be the cause of the disease. And I think I understand within China itself, people from Wuhan were stigmatized as compared to other people in China. So in a sense, it became a more focused sort of stigma. And this kind of stigma is also, of course, exacerbated when you have high-profile, influential people or politicians talking about the Wuhan virus or the Chinese plague. Subsequently, we have developed threats towards health workers, and I think we're going to be hearing about this afternoon, and other frontline workers who have been at risk with some really tragic and sad consequences. And then as we sit here today, we can say, okay, what's going on now with stigma? We have these still threats towards health workers, but we also have people who are recovering from stigma and who have recovered. And some people like that have also been experiencing stigma. Looking further ahead, I think it's worth considering what sorts of stigma we may be experiencing and looking to be happening with relation to the vaccine. If people have the vaccine, perhaps they will be stigmatized for reasons we don't yet understand. Or perhaps if they don't have the vaccine, they may be stigmatized for reasons we don't yet understand. But we need to think ahead of how this could go. Next slide, please. Different sorts of stigma. I go through this very quickly. There is self-stigma, which is where one feels I am somehow disgraceful. And I think this is often associated with HIV. People with HIV, it's been reported quite often that there is a lot of self-stigma. There is enacted stigma, whereby someone actively does something to someone else, which gives them a sense of stigma. There is anticipated stigma, which can occur when people expect to be stigmatized, and therefore they may, for example, not go for a test because they don't want to be positive, and therefore they'd rather not get the test. And then there is felt stigma, which is the actual feeling of being stigmatized. all of these can result in social exclusion and all of the problems that go with that. Next slide, please. This is my last point. Yesterday, I think it was, Melinda Gates published a paper which I thought was a really interesting report about the consequences of COVID. And she said in the introduction to this, she said, this pandemic has magnified every existing inequality in our society, like systemic racism, gender inequality, and poverty. And I think this really gets to the core of where we want to be looking at when we're looking at stigma, because wherever you have these issues, wherever you have these inequalities, you already have stigma. And all that's happening now is that COVID is exacerbating that and making it worse and making it easier for those others, as it were, to be stigmatized. So my take-home point from this would be that while we definitely need to be looking at risk communication and at messaging towards thinking about solidarity, we're in this together, let's work together to get through the pandemic, this in itself is not sufficient to actually address stigma. We really need to go beyond that. We need to be looking at bigger and, of course, therefore more challenging interventions that will be addressing stigma in a more structural and perhaps a more comprehensive way. Thank you very much.
Great, thanks so much, John. That's a great launch off to this this webinar today. So I invite everybody, remind you that if you do have questions for presenters, again, please put it in the Q&A function down at the bottom of your screen in the Zoom. Also, I want to remind you that we do have interpretation. If it's easier for you to understand this in French, there's an interpretation button, I think, at the bottom of the screen as well. So thanks, John. And before we begin with our next presenter, I think we have one more polling question about her presentation. So I think the next question is, has social distancing led to stigma? Okay, we'll close the polling in 5, 4, 3, 2, 1. Okay, and it looks like almost a tie between definitely yes and you're not sure, which is actually a good space to be for this webinar, so you can get some answers on how to find out if stigma is related to social distancing and other factors in the COVID response. Thank you. So without further ado, we'll go to our next presenter, Bina Thomas, who's a social and behavioral science researcher. Bina, welcome.
Here it is good evening. So hi everybody, I'm so glad at the response, and I'd like to thank Melinda and group for organizing this very special webinar and much needed. So the topic that's given to me is addressing COVID-19 related stigma. And I liked the polling response. Has social distancing made it worse? So let's see, next slide please. So just to give you a view of what the situation is, we are almost at 30 million globally. In India, we are at 4 million. Next. And while we are thinking in terms of numbers, you find there are different reflections of stigma. I'd like to thank John for setting the stage for this. If you look at the way stigma is reflected now, the derogatory terminologies and labeling that is being used, with labels such as suspects, recovered COVID-19 patients, even after they are recovered, they are still called patients. You have terms like super spreaders. We have a lot of rumors and misinformation, almost an infodemic through the media, and there's no other source that is left. And then, of course, there is this targeting of specific groups. In India, we have the religious groups. It was that for one time they were the ones really been given a bash up because they had a big Muslim festival going on here, and they were the Tabligis. So that was the group where vendors were not allowed, nobody would go to them, and they were the targeted groups. Then of course we are going to hear about the healthcare workers. We have the migrants, responsible for spreading COVID from one place to the other, not realizing what they were going through. And of course this terrible lack of communication and stigma has been exhibited very specific to regions, so it might vary across regions, and it'll be nice to hear the kind of discussion that we have today. And I'd like to touch on what we have personally experienced here in India, and then of course the behavior and attitudes which are multi-layered. Next, please. So I have a policy brief here, which you can later on link up to it and just see it. And that's what I came out with it, way back in March when I was helping out with a psychosocial counseling unit here. And there you find that stigma started at that time, even at the airport, where people would come back from an international travel and, the holiday and the whole idea of coming back from something so exciting was all, a complete breakdown with the kind of stigma that started in the airport. And then, of course, there was the problem of quarantine, the stigma associated with quarantine, and then the isolation, and then, of course, the problems associated with treatment. Here you see a big sticker. You can see that COVID-19, do not visit, home under quarantine. So you can imagine the kind of things that people went through. We've had stories of old people saying the gas people came there, they wouldn't even bring the cylinder. How can you expect my husband and me 70 plus to carry a cylinder? The milkman wouldn't attend, wouldn't come to our house. So nobody realized what people were going through. And so all this resulted in people not seeking care. Right? They're not even wanting to be tested. And of course, the kind of morbidity, mortality, and the mental health problems that continue to remain. Next, please. And we are going to hear about the stress and burnout among the healthcare workers, which the system can ill afford. I'm going to show you a slide of what the healthcare workers have gone through. And then you have, of course, the economic losses, because there was a sudden lockdown and people losing their jobs, people just thrown out of jobs, houses, so problems associated with housing, and even social relationships among those who are diagnosed COVID positive, even after recovery. So I'm going to bring out some narratives in the following slide. So in short, it dehumanizes people. Next. So just to give you some narratives, this is from a village in India. You wouldn't even think that, stigma has reached something where there were just 15 households in that whole village. And here is a quote from one of the respondents there. He's from the military and traveled a long distance to our village. Don't go anywhere near his house or even his street. He would definitely be infected and will infect you. This is a person who is suspected to have COVID, not diagnosed to have COVID. Can you imagine the plight of us doctors? We had an electric shutdown and nobody would come to work in my place as I'm a doctor. They say I might infect them with COVID. And then what happens if we die from COVID? We will not even have a decent burial. The kind of shots that came out on TV is the way people, even the burial, practically wrapped up and thrown into a pit. Here's another one of a COVID recovered person. My husband completed 14 days in hospital. He was cleared to go home. He was thrilled considering the isolation and loneliness that he went through in the hospital. When I told our flat association, they reacted so badly and were scared that he will still be a carrier of COVID. It hurt us so badly. Where did all our friends go? What is happening to people who lived with us for more than a decade? Next. So this is just to give you a shot of, this is what happened. The healthcare, it was a doctor who died treating COVID patients. He was not allowed to even have this burial in the cemetery, which was for them. In fact, people threw stones at the ambulance and finally they had to come back past midnight and have the burial done. Next. So social distancing, the question that we asked earlier, has it created stigma? Any illness requires social distance, social support, but in COVID, which we have never seen before, social distancing has resulted in terrible dehumanization. It's all about me being protected and not about what happens to you. Like John said, it's about me against them. Social distancing has led to broken families. We hear of even a son not allowing his mother who came from another village to his house saying, you might be carrying COVID. Total disrespect. loneliness, and mental trauma. And social distancing has also exhibited its ugly side among the healthcare providers. On the one hand, they have experienced stigma, but the other hand, they also have been responsible for stigma within hospitals who forget their oath to serve. No attending, no communication with patients because everyone is scared of being infected themselves. Next. So why do we need to address stigma? It is the one and the main point is to make us more human, to evolve strategies that promote early screening, early testing. WHO has said test, test, test. But if there is stigma, how do you expect people to agree to disclose their symptoms, to promote early testing, to have timely diagnosis and treatment? We need to build that trust in people with strong, reliable health services. We need to clear that understanding of all the disease. Like earlier said, an infodemic of misinformation and rumors is spreading more rapidly than COVID itself. Next. So what are the current gaps in addressing stigma? We need regional specific evidence on what causes stigma. We need to understand risk perceptions. We need to understand what people know. We never listen to the voices of the community. So right now we are doing, I would be happy to share that protocol is with you. We are doing a study on the perceptions of stigma in the community, and it's opened our eyes to a lot of things, but this again varies from region to region. It's not that one size fits them all. We need to think up of these terminologies across the globe, which need to be stigma-free. And one terminology I really dislike the most is social distancing. We need to have generic proposals and share it, to others as well. We need to develop interventions. It's always, you find that a lot of studies are done on the problems, but we need to think in terms of the solutions, the interventions. We need platforms like this, what we have today, to discuss on the way forward for timely interventions. Next. So again, we find that counseling has still not been advocated, not only counseling pre-testing like we did in HIV and post-testing, because people have no clue what's happening. Results take forever. In the beginning, it used to take even 3.5 days. The kind of trauma that people went through with no communication whatsoever. We heard of suicides, which still happen. And because we do not prepare them, there is no preparedness for the test, either before the test, after the test, of what is in store for them, so that they will be prepared. And then we need counseling with interlinkages to other services as well. It's so important for this holistic approach, and only then can we really walk the talk. We do not have counseling for COVID positive, not only while they are in hospital, but also once they come out, because I gave you that narrative of what is in store for them, how important it is to be able to prepare them as well as to prepare communities on how to accept people like this. We need interventions for healthcare workers to mitigate stigma. And most importantly, we need a bottom-top approach. All the time we think of solutions, but we've never listened to the voices of communities as to what they want in terms of understanding, and this is important to mitigate stigma. Next. So what is my take-home message here? Stigma is a hidden disease that needs to be treated. We need to focus on solutions through interventions and not only focus on problems. We need evidence to translate to practice and policy, and we need to act now. The problem right now that we face is communities' perception has not been addressed. We don't listen to those voices. We need to have this bottom-top approach, and I would end here. Thank you.
Thanks so much, Veena. Really interesting to hear the work that you're working on in India. And we captured some of the ideas that you had, and we'll kind of pull everybody at the end to see what we can do in terms of next steps to address stigma and the COVID-19 response. So we're going to move next to Vivian Flug, who's the regional coordinator for community engagement and accountability in the Asia Pacific region. So thanks for joining us today.
Great, thank you so much. And there.
Oh, I apologize. We have two
we have
some polling questions.
Yes.
Yeah, we'll get to those first. I'm sorry about that. So the first polling question is, what's the main tool that you've used to understand stigma? The first response is perception survey. The next is feedback mechanisms, in-depth research projects, research reports, other, or haven't used anything to understand stigma in your response efforts. Thanks, Vivian. Sorry about that. Okay, and we'll close the polling in 5, 4, 3, 2. If you want to vote, do it now. And 1. Okay, so it looks like the majority of people have not used anything to yet to understand stigma in their workplace, but some have used some perception surveys and other feedback mechanisms. And I think we have one more polling question before we begin with Vivian's presentation. Have you implemented a perception survey as part of the COVID-19 response? I think this is maybe any perception survey. Okay. And I think we can close this one pretty soon. And 5, 4, 3, 2, 1. And it looks like pretty much the overwhelming majority says no, they haven't. And some are planning to, and some have. So with that, I will move over to Vivian's presentation. Thank you. Vivian?
Excellent. Thank you so much. And great to see so much interest in this topic, which is definitely very dear to my heart as well, as it's been cropping up everywhere. As Mindy already said, my name is Viviane. I'm the Community Engagement and Accountability Coordinator for IFRC in the Asia Pacific region. And I'm today mainly talking about perception surveys and stigma in Asia Pacific, but specifically in 4 countries. So first, we wanted to find out more about stigma. And one of the things that we did in order to do that was doing a perception survey. And that was led by WHO, IFRC, and UN OCHA, but also UNICEF and several national societies, so Red Cross, Red Crescent national societies. And we've asked about knowledge around COVID-19, about communication preferences, but we also had a question on stigma. And to me, those were actually the most interesting results. We did the survey in Indonesia, in Malaysia, Myanmar, and Pakistan. And of course, the survey was translated into various languages. I think in total we have about 13 different languages. And in the first round, we got 4,993 respondents. And the survey was conducted through phone, face-to-face, and also online. That also means that, of course, these results are not necessarily representative, and we've been triangulating them as well. But they give us a first indication about some really interesting points. All of the data has gone into an interactive dashboard, and there's more data coming in. I've just posted the link to that dashboard as well in the chat box. So if you want to have a look yourself, you can, and you can also use different filters. So you can look at specific countries or filter the data according to age or gender or education. We've done kind of cross-country analysis as well, and that report is coming out actually the full report on Friday, so you're getting a little bit on a preview. And we've of course looked into a lot of the qualitative data as well and kind of compared the different data points. On the right-hand side, you see a screenshot of this dashboard, which is being updated with data from the field automatically. And one of the key findings that is around stigma was actually that 1 in 2 respondents of the survey believed that either fully or a little, a specific group is responsible for the spread of COVID-19. You can see the exact percentages in below this. And overall, we found that people in Malaysia were most likely to think that others were responsible for the spread of COVID-19, whereas in Pakistan, they were the least likely to think that somebody else was responsible for the spread of COVID-19. Now, who is responsible though? Let's play the blame game a little bit. And according to the survey results, this is actually quite different. So for instance, in Myanmar, people thought that Chinese people are mainly responsible and people coming back from a foreign country. In Malaysia, it was mainly foreigners, and this group is again split up into different subgroups. So illegal migrants, for instance, and illegal in, that depends on the opinion of the speaker, I guess, and tourists, also Chinese people as well, have been singled out once more. Malaysians have also voiced that people who have COVID-19 or people who are not following government orders are responsible for spreading this. For Myanmar, of course, if we look at the country, it has a very long and porous border with China. And at the time when we're collecting these results, which was between May and July, there were almost no local transmissions. So the communication as well was mainly it's migrant workers, Myanmar migrant workers coming back home that are bringing this disease into the country. Whereas in Malaysia, at the time of the survey, we've seen government putting a lot of very strong restrictions on and increasing detentions and so on, and have also seen other data that suggests that kind of public opinion of foreigners is not quite so positive and is kind of going down. In Pakistan, one of the topics that has come up was perceived insufficient measures related to travel, isolation, and quarantine. And people particularly mentioned the Iranian border. They've also been talking about people coming back from foreign countries, and there they mainly singled out pilgrims, so their own nationals that are coming back, and mainly the ones that are then settling sort of in Sindh and Punjab area, and as well people from China. In Indonesia, it was mainly people who don't follow government restrictions and people who are unnecessarily or perceived unnecessarily traveling to high-risk areas, and also a lack of stricter regulations such as lockdown regulations, etc. What's interesting is that some of the data in Indonesia is overall from people with a little bit of a higher education level. So that might be one of the reasons why they focus more on these kind of government measures, that they're kind of analyzing the situation and looking more at that rather than following kind of the media. Overall, we found that men and age groups over 50 are slightly more likely to think that others are responsible for the spread of COVID-19. And also that in Malaysia, for instance, in rural areas, people are actually slightly less likely to think that others are responsible for spreading the virus. So there are some key tips that we found really helpful in the region. One is to address anxieties and knowledge gaps. A couple of the other speakers have mentioned these as well. Also not using stigmatizing language. And I think that is something that we can see in the results directly when we see that in almost all 4 countries, people think that Chinese people are the ones who are spreading the virus. And that does come from terms, I would suggest, such as Wuhan virus or the Chinese virus. It's really key to engage community leaders and also to portray different people and not just ethnic groups, but of course, different people with different backgrounds in our content. Having a diverse team really helps with that. And also supporting ethical journalism. So very often we found that journalists have been very keen to actually report on these things, but they don't always get kind of the useful and verified information that they need, especially the more local journalists. And I've once more put the guide here that was done by IFRC, WHO, and UNICEF that Melinda had already posted, I think, in the chat box as well. So Action Against Stigma, what are we going to do next? We're planning to share results. We're doing that here. We're doing that through different forums that are available to us. The different national societies that have been involved are adjusting their strategy and are adjusting their programs. For instance, they're using different channels to get in touch with people. They're using, giving different information based on these survey results. We've done already a webinar for media practitioners on their role in addressing stigma, and I've put the link in the PowerPoint, so you'll get that afterwards. You can also find more resources here on Community Engagement Hub and our interagency Google Drive, of course. And you're very welcome to add your own resources to the Google Drive, because there is a number of videos, for instance, and others that might be useful to you. So finally, please feel free to get in touch. This is, of course, not anything that has an easy solution, but something that we all need to work together on in order to address this stigma. And that is everything from me at this point. Thank you very much.
Great, thanks so much, Vivian. That was a great presentation. Very interesting to see your data. So before we move on, we're going to stop for a moment and answer a couple of questions that you've had. Thank you for your involvement and activity in the question and answer box. And we invite you to keep asking some questions, and we'll try to pull them out and answer them today, or we'll put them into a frequently asked question list later as well. Additionally, I just want to highlight, if you have any ideas for particular projects or activities, again, please share that, and we'll kind of try to pull it together and pull it at the end of the session for today. So for the first question, we're going to go to John Kinsman. An individual had a question about noticing that the way that people are stigmatizing COVID-19, often it kind of resembles the way people were stigmatized about STDs in the past. Has there been any other infectious disease that have had stigmatization similarly, and how can we overcome this? And could you give a couple of examples of messaging around that?
So thanks a lot. Excuse me, it's a very good question. Any other infectious disease that has had this kind of stigmatization? Well, many, I would say. HIV is, of course, the sort of preeminent example of a stigmatized disease. But you could also look at tuberculosis, which has also, there's a lot of work that's gone on stigma and how stigma in relation to people who have TB find it difficult to access their treatment. And that's often the issue. You're stigmatized, you feel stigmatized, whether it's felt or whether it's enacted or whether it's self-stigma, and that issue inhibits you from accessing treatment. And that has been very well documented with HIV and TB. Similarly, with the West African Ebola outbreak, there was a lot of stigma to do with survivors. People would go back to their villages or to their homes after the infection was cleared, and they would find possibly their house had been burned or their belongings had been burned, and people would shun them. And if they were, for example, selling vegetables or different products in the market, people would not want to go to them. So this is a very serious problem that's emerged in many other diseases, many other infectious diseases. And it's not just an issue of, well, it's not very nice to be stigmatized. Well, of course it isn't. It really can have life-threatening implications for these people who are stigmatized as a result of these diseases. And I've given just 3 examples there, but you could apply it to many other diseases. And in terms of examples of what could be done that is more than messaging, I definitely don't want to give the impression that we shouldn't be doing messaging, because of course we should. It's an absolutely essential part of it. But I think my point here is there are so many different channels we should be thinking about taking. Messaging essentially, at least in the definition I'm using here, it involves me giving you a message. It's I sit here, I think this is what you need to hear, and I give you the message. For example, we're all in this together. Let's show solidarity. Fine, it's kind of slogans, it's kind of a way of looking at something, and it's important. But it's a one-way issue. And I think what we need to be thinking about here rather more is two-way dialogue and taking a more sort of community engagement approach. And I think that Vivian's comments just now really reinforce that, the importance of actually engaging with journalists and the importance of engaging with other influential people in the community, and actually really finding out how can we support you to actually have an approach in the way you speak about these things that will actually not stir up stigma, but will rather, through your words, it will affect the collective imagined epidemic in such a way that stigma doesn't emerge. Of course, there are some people who you can't touch, and of course the politicians, certain politicians spring to mind, and you can't change the way they do things. That doesn't mean we shouldn't try. It does mean that we should always try and focus where we're working on people who may be amenable to change. One very, very last point I just want to make before I'll give the floor back. There's one country in the EU, at least one, and I know of this one quite well, where they have an extremely good social media monitoring system, which basically picks up on misinformation to do with different diseases. And when they find someone who's working against what they believe to be the correct medically, scientifically information, they will occasionally actually approach this individual one-to-one. And they have had cases where people have been they've been then engaged in discussions with people, and it's actually turned out to be very, very productive and very positive. And the messaging from that individual has then stopped, and there have even been cases where they've actually started rather supporting the scientific line. So those would be people who perhaps were just simply not informed properly. They wouldn't be people who necessarily had a political or other agenda, but they were putting out wrong information. Engage with them, correct the information, maybe it'll be better. So there are different ways of doing it, but I think the key thing is messaging is essentially one way, whereas if we take a more community engagement point of view, we're discussing, we're getting back and forth, we're creating a dialogue, and that has probably a better chance of actually developing a good way to create a sustainable, collective, imagined epidemic, which is conducive to reducing stigma.
Okay, thank you, John. The next question will be for Bina. Bina, I think as you mentioned in your presentation, you really don't like that terminology, social distancing. And I know at WHO, we've been trying to use the term physical distancing. Maybe what other social, public health and social measures do you think have led to stigma? The ones we've often talked about were physical distancing, mask wearing, and so on. But what are some other recommendations that may have led to inadvertently to stigmatization in your experience?
That's a tricky question because there are so many, because people have not even understood why people would even wear masks or not wear masks in a country like India, which is so absolutely hot and where people are sweating. You know, how do you expect them to wear masks, and what kind of mask do you advocate? So that is something that is important. And if you look at, yes, I don't like the word social distancing. It is physical distancing, keeping a distance. Wearing a mask is extremely important, but then being able to do it in the right way, not with these with the kind of a rod kind of stick approach. That is not the way, but to be able to understand and to be able to explain to people what it does. Like I was talking to one of the people who sweep outside, says we don't even know why we are required to wear a mask, what really happens inside. They say, you know, the kind of misinformation that has come in, it's anyway, one of the things is whether it's a biological warfare, the kind of misinformation that goes, people don't know what the virus does and what happens if you have to, what a mask, wearing a mask would do to prevent the virus. So it is this importance of being able to communicate to people in a language that they understand, and the kind of confusions that go on in their mind as to what is this COVID? Why is it caused? Why do we need to wear masks? And this whole concept of, like when I said social distancing is, you know, people have forgotten what it is to be there when people need you the most. So it is, yes, we need to message, we need technology, but where is that person reaction? A person needs food next door. So what do? Is it that you message, you need something, but you have to be there. So you can wear a mask, you can keep your physical distancing and go there and give them that food, you know. So it is so important. You need medicines. There should be somebody to go there, collect it for you. You know, there are children out there who need help. The problem is people really haven't been able to understand What is it that people need? So that is why this whole social disconnect is not the right word. I agree physical distancing is an important way, a word that we need to use, but more importantly, also success stories. People who have gone through COVID to come there and to be ambassadors, to be advocates. I think that's important.
Great, thanks so much, Veena. And then we'll have one last question for Vivian. And Vivian, one of the participants asked if we could point to any data or emerging trends from actions that individuals have, or I guess responders have been using and implementing in terms of what has worked to address stigma, if you know of anything that's been effective in the response.
That's a really good question. And to be perfectly honest, I don't think we have that data yet. So we've been focusing mainly on looking into the reasons and looking into what are the needs of people. We have been working on this a little bit in terms of feedback data, where we've been seeing, okay, what kind of answers and actions have we taken in order to address people's needs around COVID-19 in more general terms, but not specifically on stigma. So I do think that's something that would be really interesting to look into more, and definitely something that, yeah, I'd be keen to explore in the future to see, okay, what are the things that we're doing that is working really well. We can, of course, anecdotally say that some things get more attention than others, but yeah, we don't have as systematic evidence for that yet.
Okay, great. Well, hopefully soon. And maybe we can have another webinar in a few months, maybe when there's more data or more activities that have occurred around this area, and see what's worked and what could have been improved. So thanks, Vivian. Okay, so we'll move on with the rest of our presenters for today. Before we go to our next presenter, I think we have a polling question. My colleague Catherine. Okay, great. So the next, we're going to move on to healthcare workers that have been stigmatized. So the question is, have you experienced or seen physical, verbal, or psychological abuse of healthcare workers due to their work? And the first answer is yes, I was a victim. Yes, the next answer is yes, I witnessed an attack happening. The third answer is yes, I heard of such an attack. And the fourth answer is no. Okay, and we'll begin to close polling in 5, 4, 3, 2, 1. And looks like the majority has heard of such an attack in their response area. Great, I'm sorry to hear that, but good feedback for the next presenter. Okay, with that, we're going to move on to my colleague, Hyo-Young Kim, who again is the focal point for Attacks on Healthcare Initiative, who works here at the World Health Organization. Hyo-Young.
Great, thank you, Melinda, and thank you to everybody for giving me the opportunity to talk about my area of work, which is Attacks on Healthcare Initiative. Can we close the polling window? I can see it still on my screen. Sorry. Thank you.
I think that you can go ahead and close it on your own screen.
Oh, I can. Okay, great. Okay, great. Thank you. So next slide, please. So in WHO, we define. Can I have the next slide, please? In WHO, we define attacks on healthcare as any act of verbal, physical, or psychological abuse that obstructs access to healthcare. So the focus is allowing access to healthcare without being obstructed by any form of violence or administrative or legal obstruction. And as part of this exercise, we monitor these incidents of attacks on healthcare, primarily in complex humanitarian emergencies. But in the context of COVID this year, we have sort of tried to monitor what's happening outside of the complex humanitarian emergency sphere as well. And we have seen a growing trend of attacks on healthcare, primarily on healthcare workers in relation to stigma or misunderstanding from the community. So I would like to share some of the examples and some of the reasons why we think this is happening with you, and then also share some examples of how we try to address some of these issues in different contexts. Next slide, please. So we find that there are maybe two main reasons how stigma leads to attacks on healthcare based on the data that we have. The first is the community fear or misunderstanding that we've heard a lot about already that has led to healthcare workers and their families being attacked. So for example, we've had healthcare workers that have been physically violated for trying to board public transport wearing their healthcare worker gear because of a stigma. And in some other countries, healthcare workers' children have been obstructed from attending schools because of fear of infection. And also some recovered patients or recovered people have been ostracized by the community as well. And also in complex humanitarian emergencies especially, but in other contexts as well, we find that this stigma, this fear from the communities is further compounded by local politics, conflicts on the ground and other local contexts, which has again further enhanced the stigma around healthcare workers, healthcare facilities as well. For example, in a country, we found that there was a lot of stigma around healthcare delivery itself because people fear that this was being used as a means to spread COVID by the opposition power to their communities. And as a result, healthcare workers were shunned and healthcare facilities were not visited at the height of the COVID infection, which has led to other health issues, compounding other health issues on the ground. So it's not just about community fear, but there are other factors that join together to really enhance the stigma that leads to obstruction to delivery of care and people's ability to attend healthcare. Next slide, please. So this is a graph. So we actively monitor attacks on healthcare in complex humanitarian emergencies using a system called the surveillance system for attacks on healthcare. And this system allows us to collect primary source information from the ground. Now, the system collects number of incidents of attacks on healthcare. We don't look at perpetrators or the causes behind these attacks per se, but we have seen an interesting trend during the Ebola outbreak in DRC, where with the increase of the number of response activities on the ground, there was a significant increase in the number of attacks over time that coincided with the trend of the disease itself and the response work. And some triangulation with other sources of information showed us that a lot of these attacks were in many parts driven by fear of infection and anger from the communities, but also were further compounded by the ongoing conflict situation on the ground. And I don't show it here, but data shows that about 80% of the attacks over this period has some kind of a psychosocial aspect linked to it. So there were threats of violence, etc., occurring as well. And also about 72% of these incidents affected healthcare personnel directly or indirectly. So the impact of these attacks were quite significant on the response operations to this disease. And we find that this trend is interestingly reflected in the current COVID-19 situation. So next slide, please. So according to the SSA, the surveillance system data that we have from 13 countries in 2020, we have about 170 attack incidents collected, which has resulted in 108 deaths and 174 injuries of just healthcare workers and patients. We don't collect civilian data here, but you can see that the impact is actually quite significant physically on the healthcare workers. And of these 170 attacks, 87 incidences affected healthcare workers. And of course, not all of these attacks were from communities or linked to stigma, but I think looking at the secondary data as well that we've been trying to collect, so beyond the complex humanitarian emergencies, which is the focus of the SSA, we have been monitoring also what's been happening around the world using media and other sources of information, which is a less formal mechanism, but we just want to understand the trend of the situation. We've collected more than 160 attacks between April and 14 September from 38 countries. And a lot of these incidents seem to be based on community stigma-related issues. So you can see that there is the trend that we saw in DRC during the Ebola outbreak is being reflected again in the context of COVID-19 to a certain extent. Next slide, please. Can I have the next slide, please? Oh, thank you. So just to say that the impact of attacks on healthcare due to COVID, due to stigma and other issues is actually quite wide-reaching. It's not just about a healthcare worker being assaulted or killed even, but the impact is far wide-reaching in that the mid to long-term impact on the society and the economy of the context in which they're occurring is actually quite significant. And this is one other reason why we're so concerned about these issues. And just to say that in the context of conflicts, they could actually constitute a violation of international humanitarian law. And of course, it violates every human rights principles out there. Next slide, please. So, I'm just going to share a couple of points of examples of how we try to address these issues. So the first point was around, of course, communication directly to the communities and the public that are maybe inadvertently becoming attackers of healthcare workers due to stigma or fear or misunderstanding. So there have been a few social media campaigns that have been launched to actively raise awareness on the need to care for healthcare workers. So the Be Respectful, Be Supportive, Be Kind campaign was something that WHO headquarters launched. And there was also a partnership with the UK government to counter misinformation about COVID. And in our Southeast Asia regional office, there was also some active campaigning on the need to protect the healthcare workers so that they can protect us ourselves in response. In addition to direct communication to the public, we found that we also need to have some more specific systematic measures for protecting healthcare workers, but also using this mechanism to enhance the status of healthcare workers in the public's eyes, just to show that how important they are for us, not just in the context of COVID, but in general for our health support. And this has been done through either legal or policy measures. So we have examples from countries where there was a country where they increased the legal penalties for attackers of healthcare workers, thereby strengthening the protective measures around healthcare workers. But also some incentives were paid to healthcare workers to enhance their protective needs, but also their status in this community by paying hazard allowance or ensuring medical insurance for healthcare workers and their relatives much more strongly than for others. And in much more volatile areas, we've also engaged active police or military protection for hospitals to ensure that they are protected. Next slide, please. And just to give a shout out to our colleagues in ITRS, who actually also developed a tool for specific measures on how to better protect healthcare facilities from potential attacks in conflict situations. So that can also be accessed. In addition, we've actually tried to collect some good practices of prevention and protection measures against attacks on healthcare directly from countries. So trying to see what has actually worked to really enhance the protection against attacks for healthcare workers and healthcare in general as well. One of them, there was a lot of discussion around the need to engage communities in operations. So it's not just about communicating to them and saying you need to protect your healthcare workers, but making sure that they are part of the response itself and the health service delivery mechanism itself, especially from the beginning of the operations, if possible, if you're an ingoing body, to ensure that they're part of the operations, but also enhancing protection measures, again, through active engagements of communities for the health facilities was also something that proved useful. And last but not least, I think the monitoring of incidents is especially important, and we have a couple of tools to allow you to do this. To better understand the trend of the issue and also to understand some of the drivers behind these incidents. So maybe I'll stop here and see if you have any questions on this. Thank you.
Great, thanks so much, Hyo-jung. Nice presentation about a very, very important issue. I just wanted to note that thank you for Laura, who shared a recent report that was done by Canada on stigmatization in healthcare systems. It also includes an action framework for building an inclusive health system. So please check that out in the chat box. Also, my colleague, I think Samira Suri, may have seen input the social stigma guide that was developed by WHO, IFRC, and UNICEF a few months ago in the COVID response. So thanks for that. So we'll next move to another colleague that's joining us from Japan, Rio. But prior to his presentation, we just go to one more polling question to get a sense of where you're at in terms of materials. So that polling question is, have you ever used informational materials in your work on stigma? Never, only a few times, often. I've developed information materials just for use in emergencies. Okay, and we'll wrap up this poll in just a few seconds. 5, 4, 3, 2, 1. And we'll end it there. And it seems like a pretty even mix of never, a few times, often. So all over the map for you, Rio, in terms of people that have used stigma information in their response. So I'd like to welcome Rio Morimitsu from Japan, who's the chief psychologist for the Japanese Red Cross Suwa Hospital, who's created a package toolkit on the 3 faces of COVID-19. Rio, thanks for joining us. I know it's late at night there.
Hi, can you hear me and can you see my slide?
Yes.
Okay, great. Well, good evening from Japanese time. Thank you for having me here today. Today, I'm going to talk about the national level response in Japan rather than global, which is about how to raise awareness among communities. In the presentation, I will introduce a practical tool that we have developed for this pandemic. So our primary aim for developing the tool was to address MHPSS issues, mental health and psychosocial issues, which includes stigma-related issues. The guide is called 3 Faces of COVID-19. My name is Rio Morimitsu from Japanese Red Cross. Let's get started. Yeah, first, I'd like to invite you to get into the context in Japan. Do we see stigma-related issues or incidents since COVID-19 in Japan? The answer is yes, unfortunately. I wouldn't say it's common or many, but we have seen stigmatization against medical professionals and the family of those. For example, children of nurses were excluded from some daycare centers, which created a big discussion in Japan. And we have seen hate speech and blame against those infected. This is particularly active on social media. And that's why we have developed this guide. It's a picture story guide for communities, like a cartoon. And again, this was meant to be an advocacy on psychosocial issues in the COVID-19 response, including stigma issues. And luckily, the guide has been widely accepted and used in Japan and already translated into some other languages. And I would say our advocacy with this tool has been quite successful in terms of coverage of people. We've got over 600 official requests to use and cite within 4 months. That's approximately 4 times the number of requests to the Japanese Red Cross in the last whole fiscal year. And of course, the people share it and retweet it with their personal social media. So for the next 6 or 7 minutes, I'm gonna introduce what it is, and I'm happy to share lessons from my experience. So the question is, why so accepted and why so widely used? As you see, I'm gonna talk about those 3 key elements. Now, first of all, the timing was good. The graph shows daily confirmed cases in Japan, the daily confirmed cases of COVID-19 in Japan. We started raising awareness on stigma at the very early stage of the pandemic. We published our first MHPSS guide the day before WHO declared pandemic. The first one already included advocacy on stigma, but it was only for our staff and volunteers within Red Cross movement. So we revised it, targeting the general public. And so but the second one, the 3 Faces one is released very early stage of the pandemic. So information was provided when the community needed most. And, this one, yep. And the second element for the public acceptance is that we deliberately design messages to draw attention. So this is a community guide for the public. It should be handy and easy to read, written in simple languages. So we also intentionally used cute illustration of the virus. Look at this face. Is it scary? No, somewhat cute, isn't it? This is a tiny tip, but it makes a huge difference, I believe, because Here's a simple formula. Fear helps grow stigma. So if you feel fewer fear among community, that leads to more stigma. So this is why we have to be very careful not to create scary nor aggressive image of the virus. And the title is super important as well. It begins with 3 phases of the COVID-19. Then people go like, wait, a virus is a virus. How come they have 3 phases? You see, this is an entry point to draw attention. And the other thing is that the guide answers question of what is happening and why regarding influences that the people are receiving every day from the COVID-19. And the bottom line, our key message is the bottom line is like this. This is not only a health crisis, but also a psychological and a social crisis. And we explain this idea within a single picture slide. The idea is the virus brings 3 influences on us. That is sickness, fear, stigma. And the tricky part is all these phases are interconnected and compose a negative spiral. Sickness creates fear, fear creates stigma, then stigma ends up spreading more diseases because people are likely to hide their symptoms if they are afraid of being stigmatized. That's the idea of 3 phases. We got so much positive feedback from communities. For example, when we explain the relation between fear and stigma, the fear drives us to keep distance from the suspected and stigmatize others. We do this because it's based on our human instinct for survival. The more we are afraid, the more we want to protect ourselves. So it's a defense mechanism. We have it. So people agreed and appreciated when we explain this, like, oh, this is so true. This is happening inside of me. So guide basically tells you this is not only about infections, but this is all about us. This is all about the communities. So with the help of this idea, I think community members recognized how easily we can be trapped into this negative spiral. So this is a warning part. Lastly, we try to empower people as much as possible by providing possible solutions. Here again, this triangle is quite useful to suggest or come up with counteractions. And basically, there are 3 types of things we can do to break the spiral. The first thing is personal hygiene. Self-protection is one of the best prevention measures. And then you can also take care of yourself by using PFA principles. PFA is psychological first aid. I'm not going to go into the detail, but you can look at yourself in the situation and listen to your voice and link yourself to resources. By doing this, you can calm yourself down. That's another contribution. And in sending respect and sharing do your part mentality in your community is another solution to reduce the stigma. And again, we put all of these important suggestions within a single idea. And then we wanted to empower people by letting people know they are not powerless. Having options in their hands, the people can be motivated to take actions. So taking any of these 3 approaches could contribute to reducing stigma. That's how we try to empower people. So probably that's the key why people accepted and appreciated this guide. And that leads me to the conclusion. So, well, yeah, here are some lessons learned from our experience. Of course, the design matters and the words matter, timing matters, but I'd like to highlight only one thing here. Well, probably empowerment is the key for the to community engagement. So if we want to effectively promote community engagement, well, empowerment is maybe important more than the giving guidance or teaching. So my final suggestion is, well, let's empower people to promote the community engagement and the empowerment with a little bit of guidance. So that's the balance is quite important, and but not too many warning. Empowerment with a little bit warning. That's my suggestion. And finally, I'd like to express my sincere thank you to my colleague and team. So without them, we couldn't do that. Thank you very much.
Great. Thank you so much, Rio. I really appreciate hearing how this worked out well and your guide and work that's done in Japan. I'm just looking through some questions. And I think an individual asked earlier, as a young individual, obviously this is coming from one of the participants, not so much me, what can we do to help improve the issues of stigma or help combat stigma with the way we work in society these days? Do we have any recommendations, Rio, or any of the other presenters?
Can you repeat that again, Melinda?
Sure, I'm sorry. One of the participants asked, as a young individual, what can I do to help improve the issues of stigma around COVID-19?
Can I take that?
Sure.
I would say that the young can really do a lot. I think what's happening with this whole lockdown is that they're all the time either on their computer or in their digital world, that they have failed to really reach out to human beings. So I would say that just being able to make people realize that you're available for them. Here in India, like I said, we have so many people who need help, just like arranging for their food, buying their medicines, just talking to them. And something that we have done as a family is just calling them people. We just get the numbers of people who are tested positive, call them morning and evening just to find out how they are. And young people, just be there for people, especially the older people, because most of their children are somewhere else. They stay alone. I think the young, and also being a role model so that many more will join you. I think that is going to be a great service that you can do for COVID, because I think you can really help to see that people are not socially distant. And there's so much that you can do in terms of also being able to communicate to them. I liked what our last presenter also talked about, a very easy way for people to understand, and even being able to advocate, whether it's for masks, being able to say that to your own circles, your own peers, because young people are the ones who, you just walk on the road, you find they consider it all a joke wearing a mask. It's below their nose or below their chin. Being able to explain to them and to be out there making a difference. Everyone talks about problems, but I think you can be a forerunner to think in terms of interventions and solutions.
Thanks so much, Veena. I think we have another question from another attendee regarding quarantine in cities. Because certain cities get quarantined or individuals are in quarantine as we move in and out of lockdown, another term that we're not such a fan of. So what can we do to help decrease stigmatization of individuals that have had to go through quarantine? And the other lead-on question is, how much is media contributing to stigma? Rio, would you mind taking this question?
Okay. Well, fortunately, the Three Faces Guide is not only the guide we have developed. We also developed the guide for those who are quarantined, which is focusing on, again, psychosocial aspect for those experience quarantine. And we put the message in that guide. So, well, it's very important for other peoples and the friends and neighbors and families not to make the people quarantine, they be isolated. So, well, I think it's a key. The families and the friends and the neighbors can take important role, make them feel comfortable and not feel lonely. So that's something we can do as a neighbor or family member.
Thanks, Rio. And I think we have another question for Hyo-jung. You've taken a lot of the information about a stigmatization against healthcare workers in really conflict areas. What's the easiest way of maybe taking what's been learned in those settings and address it to COVID-19 response, where there's not necessarily conflict, but nevertheless, healthcare workers are really being focused on? Are there some quick things that as responders, we need to really be taking from your lessons learned and applying right now in the response?
I think one of the key lessons that many communities in conflict situations, because that's what we're looking at, did bring up was a need to really engage communities, but it's not just about talking to them, but it's about pulling them into the operations, making them they'll be part of the response efforts. It's not just you are the victims and we are going to come and treat you, but you are going to be part of the response efforts. So engaging them to be part of that response, I think it's a key element that we learned works to really help to protect, because then these people, these community people become the conduits to actually protect healthcare from being attacked. So they are in conflict situations, they often act as the early warning elements to warn healthcare facilities and healthcare workers of impending attacks so that they can protect themselves. But in other situations, they can actually actively engage in making sure that the potential perpetrators do not come near the healthcare workers or the healthcare facilities. So I think similar lessons could be learned in non-conflict situations as well, where engaging the community is not just as a talking to person, but as part of the response would be really important.
Okay, and are there ways that healthcare workers can best report an attack?
That depends on the context. If you're in a situation where there is an operating WHO office, I think the easiest way would be to contact the WHO office, and then we can try to get the reports through the surveillance system that we have activated. If not, I know different governments have different mechanisms where you can report these attacks. Not all governments have this, unfortunately, but I think many do. So that would be another channel that you could report this to. But I'll be happy to share further information depending on the questioner's context. So if you could share my contact details afterwards, I think we could have a bilateral dialogue on this as well.
Okay, great. Yeah, and I think that maybe the participants will want to contact many of the presenters. So we'll find a way to do that when we share the PowerPoint presentations, which I think we'll do through a link. So I'll just double check on that. So thank you so much, Hyo-jung. One last question. I think I might direct this back to John. And then, John, we can move on to the closing remarks after you answer the question. An individual, Ulrich, has asked, again, that when it comes to COVID-19, it's sort of like a double stigmatization against those who also have HIV/AIDS. So what are the strategies we can use to unstigmatize both infections and continue delivering service to best help fight both HIV and COVID-19? John or Bina? Maybe John.
Oh, you just throw that one at me without warning. That's a big one. It's such a difficult question. Because I mean, we all know that we've been fighting stigma against HIV for 4 decades nearly. So it's such a challenge. It's such a challenge. But what certainly, I mean, I've worked in Uganda quite a lot on HIV, and when antiretrovirals came in, it was very clear that there was a sort of a shift in the whole tone towards it. It was no longer a definite death sentence. It was actually something people could live with, and people would say stigma is going down. And I was never quite sure if that was completely true, in the sense that I think stigma was still there, but it changed. I think there was still a degree of stigma, but it changed qualitatively. So in spite of all of the efforts, even in a country like Uganda, which certainly when I was there, which was the 90s and the early 2000s, was really doing incredibly well against HIV, there was still this issue with stigma. So in response to your question about what can we do to reduce it, also in relation both with HIV and with COVID, I think if you come up with the answer to that one, then you're doing very well. But really, I think that the some sort of conclusion has to be little step by little step. Community engagement at slow, steady, consistent, trying to get the message across, trying to engage, trying to understand, trying to listen, hear what people's issues are. There is definitely no magic bullet for this. And I think that's the thing we have to realize. This is a long-term issue that we have to deal with. I think that would be really my probably not very satisfying response to your very important question.
But it probably shifts right into what we can do right now to address many of the issues that have been brought up in today's webinar. You had some reflection?
Yes, I did. And I must say, it's been fascinating to be here and to listen to the presentations and also to read all of the comments from everybody. And thank you for all of those, and both in the chat and also the questions that came through. And there were many questions that came through or points in the chat. I mean, there's too many for us to respond to straight away. And you just think, oh, that's an interesting one. I'd like to engage with that. I'd like to engage with that. And actually try and really dig deep and see how we could work through the points here. So it really struck me that with the amazing array of experience that we have here around this virtual table, I mean, literally around the globe, we had over 300 people attending. I think what could be extremely useful would be for people who are engaged in this issue, if you have something to share, to actually send your experiences and to send your protocols or whatever it may be that you have to Mindy and team at WHO to, I think, develop some sort of a compendium of good practice. And it's rather ambitious, but I feel like this is a wonderful opportunity to use what's around here right now and actually strike while the iron is hot, bring in the materials and see what people are doing across the globe. Because I think one of the big problems we face here is that there is really very little actual evidence of effectiveness of different measures, of different approaches that we can take. And I think one of the real challenge here is methodological, in that if you have an intervention, you have a nice intervention, to ascertain causality between your intervention and a reduction in stigma and a consequent further uptake in services is extremely difficult. So showing impact, there were a couple of questions there. How can I show that this works? What works to do this? It's very, very difficult to actually really show that anything works on this. What we can do is to look at it in a perhaps more qualitative way, to talk to people and try and understand their experience of interventions, if they have something they could share on that basis. But getting, you can't do a randomized controlled trial of this sort of thing. So the sort of gold standard tool for establishing effectiveness is not really available for this. So let's try and take a different approach. And I'm going to actually share, in the chat right now a link to a survey that's been developed by WHO Euro, which is all sorts of behavioral issues to do with COVID. And I strongly encourage you to have a look at that. It's quite long, it's quite detailed. It's actually 21 pages worth of questions. So you may not feel like all of these issues are relevant, but I think, given the opportunity to pick and choose a little bit, you could actually highlight certain areas within this questionnaire and actually investigate in your setting what's going on. So I would say two things. Number one, we need more evidence. So this is one possible way to take that forward. Have a look at this questionnaire. But when you're doing this, also don't forget qualitative approaches to understanding people in people's experiences in a different way. And number two, and I hope this is okay, Mindy, for me to say this, send your experiences to Mindy and the team here of what you are doing to address stigma in your setting. So in other words, I would love to see a compendium of good practices. What are we doing collectively? And perhaps this could be a really, really good way to share all the lessons learned from yourselves and your colleagues across the world. Over.
Okay, great. Thanks, John. So with that, I think what I'm hearing is that we want to kind of build a community of practice around stigma so we can continue to work on this together. So I will sacrifice my email box if when you send me information, please put stigma in the subject line so that I can decipher that from all of the other hundreds of emails I'm getting, sadly, still on a day-to-day basis. So my email address is mfrost, F-R-O-S-T @who.int. So that's mfrost@who.int. We'll collect what you bring together and then kind of feedback and have a future webinar that kind of covers where we're going next. And we've captured some of the things that you've put in the chat room. So thank you very much for sharing your documents there and other ideas. Before we say goodbye, I just want to ask one more question. If you don't mind doing one more polling question, I'll ask my colleague Catherine to put that up. And it's just to find out what future webinar topics. We're going to do this every other week from now into eternity. This is not just a COVID-19 thing we want to do. We really want to build this area of work in terms of risk communication, community engagement, social behavioral science. So what topic would be most interesting to you for a future webinar? Trust and how to measure trust in the COVID-19 response, participatory practice, which would lead to community-led decision-making, risk perception in the age of COVID-19 fatigue, or some other topic you might be interested in. And please share that topic in the Q&A function below if you have something else you would rather hear from us. And let that one go a little longer if you don't mind voting. I think it's only one choice, unfortunately, but we would probably put all of these in a future lineup. So it's just maybe a matter of which we'll hear about next. Okay, and we'll close this polling in 5, 4, 3. Last second to vote. 2, 1. Okay, and it looks like the answer, ever so slightly, is risk perception in the age of COVID, participatory practice, and then trust and how to measure trust, a very difficult topic. And then we'll look in the Q&A function to get your other ideas. So listen, a big thank you to John, Bina, Hyojong, Vivian, and Rio for joining us today, especially those that are in Asia for joining us in your evening time. Thank you very much for sharing your experience and your expertise. This has been very informative, but just the first of what we hope will be a few webinars on stigma. So thank you very much. And participants, thank you very much for this hour and a half of your very valuable time right now. I think the most valuable thing we have to share is time. So thanks for spending that with us, and we'll see you in 2 weeks. Thanks. Bye-bye.